going to be like a combine of unit 1 and unit 2?
For lab? No, it'd be unit 1 by itself.
Okay.
There's enough, more than enough in unit 1 to test you on.
Will the heart be unit 1 then?
No, heart will be in its heart and blood vessels and assessments will be all by itself. So. Okay, let's working condition here. Thank you. So we are going to take a look today at the human heart. Next week, we will be dissecting hearts. They're not human. They'll be beef hearts, but they're close enough, other than the fact that they're bigger. The human heart. Let's see if I want to say anything. Okay. Let me start with this. Oh, this is nice animation there. Okay, we've seen enough of it. Let's go on. The human heart is about the size of your fist. If you make a fist and place it in the middle of your chest, that's about, or right in the sternum, that's about where your heart's located. It weighs less than a pound. The pointy end of the heart, the apex, points towards your left hip. So if you know where your iliac crest is, then that's on your left-hand side. That's where the pointy end of the heart points in that direction. It is, let me work. So it is between the second rib and the 5th intercostal space. So if you come down to the second rib and you have the intercostal space there, the space between the second rib and the that is the 5th intercostal space is the space between the 5th and 6th rib. So it is slightly to the left of the midline, and it's in front of the vertebral column and directly, more or less directly underneath the sternum. The back side of the heart actually is tilted towards our right shoulder. So you get your framework around there, where it's located. So, and this is, if you want to get a better picture of my description, my vocal description, take a look at this. You can see exactly where the heart's located. Here is the 5th intercostal space down here, right above the diaphragm. There is the second rib right there. And we go in that look, we're in this location here with the apex pointed towards the left iliac crest and the posterior surface of the heart pointing towards the right shoulder. And the bulk of it is directly under, we are directly underneath the sternum, more or less. Okay, now, the heart is a double pump. It pumps to the lungs, it pumps to the body. The right side of the heart sends blood to the lungs, and the blood comes back to the left side. The left side of the heart pumps to the body. We call it the pulmonary circuit to go to the lungs, and the systemic circuit goes throughout the body. When we send blood to the lungs, it gets rid of its carbon dioxide, which is the most important thing it does, and also picks up some oxygen. Our blood has more than enough oxygen in it. Excuse me. Our blood has more than enough oxygen in it. I'm going to cough again if I don't take a drink. Okay. It's still not going to work, but I'll keep trying. Pardon me. When it says the right side of the blood receives, the right side of the heart receives blood that's oxygen poor, that's not true. The blood is about 80% oxygen saturation. Normally we like to be around 98%, somewhere in that neighborhood, but it only drops to about 80%. It is, so oxygen poor is not a good term. It has less oxygen. A typical red cell only gives up about 20% of its oxygen on each pass through the body. What we do is when the right side of the blood heart pumps blood to the lungs, it gives up CO2 and brings itself back up to the 98% oxygen saturation levels. We like that. We like to have full saturation, but we only use about 20% every pass through the body. But we do get rid of carbon dioxide. The left side of the heart pumps to the whole body, to the brain, to the muscles, to the organs, and then that eventually comes back to the right-hand side. So we are supplying nutrients and supplying oxygen to the systemic tissues. That blood is going to come back and end up in the right side of the heart, go to the lungs, get rid of the CO2, become re-oxygenated as if it was ever depressed on oxygen, and then go do the whole thing again. So we have parallel pumps. We have parallel pumps. We have two different circuits. We have the pulmonary circuit and the systemic circuit. The atria, the top two chambers of the heart, are the receiving chambers. These are the receiving chambers here on the top of the heart. Let's see if I can get the camera to come on. You see on the animation here, which isn't the best animation, but the top two chambers of the heart are called the atria. The right atria and the left atria. They are the receiving chambers. The right atria receives blood returning from the systemic circuit. Everything that has gone out and has come back around is received on the right atria. The left atria receives blood coming directly from the lungs prior to going out on the systemic circuit. Now the right ventricle, below the right atria, is going to pump blood up to the lungs. That's the pulmonary circuit. The right atria receives blood that's lower in oxygen and high in CO2, and it passes it to the right ventricle. The right ventricle pumps it to the lungs to get rid of the CO2 and to pick up more oxygen. That blood returns then to the left atria, which passes it to the left ventricle, which pumps blood to the whole body on the systemic circuit. The atria are the receiving chambers. If we look at our model here, let's see if I can get this to work for us. Here we can see on our heart model, we can see this is the right side of the heart right here. And this chamber is that you see in here is the right atria. This is the right atria. And this is going to receive blood from the systemic circuit coming into here. It's going to take that blood. It's going to pass into the right ventricle. Through, there we go, there it is. Through this valve that is right here. And you go through that valve there and into the right ventricle down here. And the right ventricle will then send that blood up this large artery here to the lungs. On the left-hand side, we're going to receive that oxygenated blood in the left atria here. It's going to pass through this valve here into the left ventricle down here, and that's going to go out this large red vessel here. This is the aorta, largest artery in the body, and it's going to go there into the systemic circulation. So we have these two parallel pumps, these side-by-side pumps, the amount of blood leaving the right side has to match the amount of blood leaving the left side. The volume in milliliters has to be equal, or else bad things happen. We'll talk about those bad things shortly here. Okay, so left side of the heart, left ventricle pumps to the systemic circuit, left atria receives blood coming back from the lungs. The right side, the right atria receives blood coming back from the systemic circuit, and the right ventricle pumps to the lungs. Okay. Our heart is covered with serous membrane. The outer covering of the heart is called the fibrous pericardium. It anchors our heart. It anchors our heart in place. It is going to hold us to the inside of the chest wall, anchors to the mediastinum. It's also going to create enough back pressure on the heart by pressing against it, by squeezing it a little bit, so that we don't overfill the heart. Because it's entirely possible to put too much blood in the heart. So we keep some back pressure here with this fibrous pericardium. Now, underneath that, we have the serous membrane pericardium. We have the parietal pericardium, which is directly underneath the fibrous pericardium. And we have the visceral pericardium, which is stuck to the surface of the heart itself. Remember, we always, when we're dealing with serous membranes, we have a parietal layer and a visceral layer. The parietal layer is usually stuck to the lining of the cavity, the chamber, whatever. And the visceral layer is stuck to the surface of the organ. In this case, we have the visceral layer attached to the surface of the heart, and the parietal layer is attached to the lining of the fibrous pericardium. The visceral layer is called the epicardium. It's on the outside of the heart. It's on the surface of the heart membrane, right along in covering the heart itself. Now, if that forms a space, if you will, should never have taken the heart off its stand. There we go. Okay. We have a cavity between the visceral and the parietal layers. It's filled with serous fluid. Yeah, it'll stay, maybe. So, maybe. So, we have a cavity between the two layers. It's filled with serous fluid that functions as a friction fighter. We don't want any friction when the heart contracts. We want to protect the heart in its sac. Its pericardial sac has this serous fluid inside here. So every time the heart contracts, it's not rubbing up against anything that's going to cause friction. Because our bodies don't like friction at all. So this is what the pericardium looks like. Here we see, this is the visceral pericardium stuck to the surface of the heart wall itself, or stuck to the epicardium, if you will. There is the parietal pericardium, the outer covering of the heart when we're dealing with these serous membranes. The inside, between those two layers, is the pericardial cavity, the area that's filled with fluid. Now, the pericardium does a very good job of protecting our heart. We want to make sure that when we have if there's a penetrating injury to the heart, or if a vessel has been damaged in the heart, that we're not bleeding into the pericardium. Because if the pericardium fills up with fluid or blood, it can actually squeeze against the heart and cause the heart to stop. So it's entirely possible for that to happen. Oops, let me go back. I got carried away with myself there. Okay. And again, there's the parietal pericardium on the heart itself right there. It's the outer layer of the serous membrane. Pericarditis, problem. Like any other structure in our bodies, we can have inflammation. The Pericarditis causes the surface of the pericardium to become rough. It makes creaking sounds. It sounds like a squeaky rocking chair going back and forth on a wooden floor. It squeaks, and we don't want that. The human body shouldn't squeak when it moves. The surfaces are rubbing together when the pericardium becomes inflamed. Another condition is known that I was talking about was cardiac tamponade. If the pericardial sac fills up with fluid, blood or whatever, if something's leaking into that space because of blunt force trauma or a penetrating injury, it will compress the heart and prevent the heart from contracting properly. So we have to draw that fluid out if something's going on there. A lot of, and some sort of penetrating injury, a knife wound, a stab wound, a shot, even blunt force trauma can cause cardiac tamponade. A person injured in an auto accident or slammed against the windshield or the dashboard, or maybe the airbag just deployed very vigorously, and slammed them back. Now in the heart wall has a very unique organizational pattern here. The outer layer of the heart, the epicardium, is nothing but is part of the pericardium. It's the serous layer of the pericardium. It's the visceral layer of the pericardium. So that's the outermost wall of the heart is the epicardium. It is the visceral layer of the serous pericardium. Underneath that, we have the myocardium. We know it's cardiac muscle because it meets myo and cardium. So it's cardiac muscle, but the cardiac muscle is in bundles, spiral-shaped bundles. Notice how on the slide here, how we have these circular patterns and how they're interlaced. The cardiac skeleton has connective tissue that goes across the muscle cell, the cardiac muscle, and helps to anchor the muscle fibers in place. The reason we do that is that not only do we support the valves and support the large vessels, what we call the great vessels, but we keep the action potentials. We keep the action potentials. Remember what an action potential is? It's a nerve impulse. The action potential in our heart starts at the atria and goes down through the middle of the heart to the apex and then comes up. And we want contraction of the ventricles to contract from the bottom up. And so by using this connective tissue, we can direct which way the action potential, the nerve impulse, will travel down the heart and come up the way we want it. And then the outermost layer is the epicardium, the middle layer, the myocardium, where we have the bands of muscle, and then we have the endocardium. This is the innermost layer. This is equivalent to the layers of the blood vessels. This is what's lining the inside of the chambers. This is what covers our valves too. And we do not get oxygen and nutrients from what shows up in the chambers. The heart has its own circulatory pattern. It's a very common belief that the heart gets fed by what's inside the four chambers, and that's not true. The heart has a very sophisticated circulatory system. In fact, the first 5% of blood leaving the heart in the systemic circulation goes straight to the heart. So when the left side contracts and sends blood out to the body, the first 5% of that blood comes back to the heart. It's going to get the best of the blood. The greatest amount of oxygen and greatest amount of nutrients are going to the heart first. So we have the four chambers, the two atria, the two ventricles. We have what's known as a septum, the interatrial septum that divides the the left and right atria. We have a structure known as the fossa ovalis, which is the leftover foramen ovale in the fetal heart. And we have an interventricular septum also. Now let's show you what they are. We take a look at our heart. Let's see what we've got here now. Here we see the right atria, and within the right atria, we see a little structure here that's labeled 55. Now this is the fossa ovalis. Now, when we were developing in utero, our heart had a opening between the right atria and the left atria. Normally, blood comes into the right atria here, into the right atria, and then passes through from the right atria into the right ventricle here. And it comes into the right ventricle right here at this valve, and then goes up into the pulmonary circulation. Well, our lungs don't work until we're born. Our lungs are still, we are in utero, we're floating in the amniotic sac filled with fluid, and our lungs aren't functional. Our lungs don't become functional until we take that first breath after delivery. What we do when we are in utero is blood comes, blood comes back from the placenta, it goes into the right atria here, and instead of going into the right ventricle and into the lungs, we bypass that, and there's this opening right here. Let me zoom in on that. This opening, there we go, right here, that is the fossa ovalis. That is the remnants of the opening between the right atria and the left atria. Because what would happen is when blood comes back from the placenta, it goes into the right atria, goes through here directly into the left atria. We bypass the right ventricle completely. We don't use it because there's no reason to send it to the right ventricle because the lungs aren't working yet. So that is the foramen ovale. Everybody has one. And we use the term foramen ovale or fossa ovalis interchangeably in here. It was the hole in our heart that closed at birth or shortly thereafter. Sometimes it doesn't close properly. Sometimes it doesn't close for forever. And sometimes it closes within a year. But the failure of that structure to close is the most common birth defect in children, and it's easily fixed. Now back and pick this up on this. Okay, the interatrial septum and the interventricular septum. Let me show you where they are. This wall here is the interatrial septum, this right along here, because it's between the right atria and the left atria. Here we go. There's the left atria, here's the right atria. There's a wall that separates the two internally. It is the interatrial septum. Now, the interventricular septum is this wall between the right ventricle here and the left ventricle over here. So we have a much thicker wall. The wall between the atria is very thin. This is a much thicker wall because we have much greater pressures. Blood coming into the atria are under very low pressure. Blood leaving the heart is under high pressure. Okay. now. Okay, moving on. So here's our illustration of these structures. We can see there's the right atria, there's the right ventricle right there. Here's the left atria, here's the left ventricle. Blood returns to the right atria from the systemic circulation, passes through this valve here called the tricuspid valve into the right ventricle. It is then pumped through this valve here called the pulmonary semilunar valve into the pulmonary artery, which goes to the lungs. That blood returns to the left atria through these pulmonary veins, through the mitral valve into the left ventricle, and is pumped through the aorta to the systemic circulation. Notice the thickness of the wall of the left ventricle as opposed to the thickness of the wall of the right ventricle. The left ventricle has to raise it to exceed pressures of at least 100 to 120 millimeters of mercury. The right ventricle only has to go above 20 to 25 millimeters. The pressure in the pulmonary trunk, this artery here, is very low. The pressure in the aorta, the largest blood vessel in the body, is very high. Okay. A couple other terms we encounter on our heart. So we've seen the right atria, the left atria, the interatrial the inner atrial septum, the wall between the right and left atria, the foramen ovale or fossa ovalis. We've seen the interventricular septum. Now we have what's known as the coronary sulcus. The coronary sulcus is a groove that runs between the atria and the ventricles. You can just see it here. Let me switch over to the camera. The interatrial, the sulcus is this area. It's a groove that runs between the atria and the ventricle. So here's, you can see part of it here. There's a big artery that sits right along in here, and it continues all the way around. You can see part of the sulcus here on the back side, posterior surface of the heart. It's a groove that goes all the way around the interventricular the sulcus. Bring up that text again so I'm not saying the wrong thing. Yeah, the coronary sulcus and the atrioventricular groove. It is a groove between the atria and the ventricles. And above that groove are the two atria. Below that groove are the ventricles. It goes all the way around in here. We have an anterior interventricular sulcus and a posterior interventricular sulcus. Now they are located on the front and back of the heart. They are the location of very large coronary arteries. This is the anterior interventricular sulcus right along in here. This is the front of the heart. And we have a very large coronary artery, and we have a large coronary vein called the cardiac vein right here. And in the posterior surface, we have the posterior interventricular artery and the posterior interventricular vein. So we have these two sulcuses that are dividing up the heart, front and back, anterior and posterior. We're dividing it up like that. Plus, we're also having a sulcus between the atria and the ventricles. Okay. Now, this gives you an even better perspective. Here we see the anterior ventricular artery. It's setting in the anterior interventricular sulcus. Remember, a sulcus is a groove. Anterior means the front. If our groove says, if the name of the groove is anterior interventricular. That means it's in the groove between the ventricles in the front. Anterior interventricular, the groove between the ventricles in the front. And the artery is called, it's called the anterior interventricular artery. It sets in the anterior interventricular sulcus. Sulcus means groove. Interventricular means between the ventricles, and anterior means in the front. And if you have an anterior, it's like I keep telling the AP1 classes, you've got a posterior. And so there's a posterior interventricular sulcus and a posterior interventricular artery setting in the same spot, but only on the posterior surface. And that is the divider between this in the front and the back are the dividers between the right ventricle and the left ventricle. And so, and the left ventricle is much, much more powerful than the right ventricle is. Okay, so those are great landmarks to know your way around. Notice where we see right here, the right atrium above the right ventricle. There's a groove here. This is called the coronary sulcus. The right coronary artery is on the right side of the heart. The right coronary artery is in that sulcus. Over here, the left coronary artery, because if you've got a right, you're going to have a left. The right coronary artery is in the coronary sulcus. The left coronary artery is in the coronary sulcus. These are very, very important landmarks for our heart, to know your way around the heart, to know what these large veins and arteries are called. Usually, the artery and vein will share the same name. There's only a few places where we don't. Like, for example, we have the anterior interventricular artery sharing the sulcus with the great cardiac vein. But usually, a lot of times we're going to have the artery and the vein will share, the same name. Like, for example, left pulmonary artery, left pulmonary veins, right pulmonary artery, right pulmonary veins, things like that. So when we get into looking at blood vessels, you'll see that a lot of them, arteries and veins, are going to share the same name. Okay, now, backside of the heart, we have the right ventricle and the left ventricle. We can see the posterior interventricular artery and the posterior interventricular sulcus. And we have the middle cardiac vein running right beside the posterior interventricular artery. Posterior means backside, interventricular, between the ventricles. The sulcus, it's the groove between the ventricles, and we have the posterior artery running through there. Something we do see in the back posterior surface of our heart, see a large blue structure up there. That's called the coronary sinus. As I said earlier, the first 5% of blood that leaves the heart goes straight back to the heart. And in the circulation pattern for the heart, we return all that blood into the right atria. We collect that blood in the coronary sinus first. So in this structure on the posterior surface, this large blue structure in the middle of the backside of the heart, that's the coronary sinus. And there's an opening inside the right atria for the blood that's collected there to go back into the right atria and then go through the circulation pattern again. So the first 5% of the blood leaving the heart comes back to the heart immediately. And then the circulation through the heart is collected on the venous return into the coronary sinus, where it's dumped into the right atria. Okay. Notice on the backside also, you can see the pulmonary veins. You have 4 pulmonary veins which all discharge into the left atria. You've got the right and left pulmonary veins coming from the right and left lungs. Remember that arteries leave the heart and veins return to the heart. Arteries leave the heart, veins return. And so the right pulmonary veins are bringing blood back from the right lung, and the left pulmonary veins are bringing blood back from the left lung. The pulmonary arteries, the left and right pulmonary arteries, are sending blood out to the lungs. They're taking blood away from the heart. It's that one place where we have oxygen-rich blood coming back to the heart in the veins, and oxygen-deficient blood sort of going away from the heart in the arteries. Okay. Now so the left atria receives all this blood from the lungs and on the 4 pulmonary veins. The right atria is getting the whole systemic circulation delivered to it through 2 very large veins. Because remember, everything is about, venous return is how the heart gets its blood back. We have what's known as the superior vena cava coming in on the top of the heart, going into the top surface of the right atria. We have the inferior vena cava going into the bottom surface of the right atria. We take a look at our, and I promise I won't do this much anymore. We take a look at the inside of the right atria. We can see this opening here down at the bottom in the dark red spot right there is the opening for the inferior vena cava. Now it's inferior only in the sense that it's below the superior. It's coming into the bottom of the right atria. The inferior vena cava is a huge vein. It's about 1.5 inches across, and it runs from the heart down to the inguinal region below the level of the belly button, and it drains the lower 2/3 of the body. The superior vena cava only drains the head, the neck, and the top portion of the thoracic cavity. But because it's on top, it's called superior. Here is the opening for the superior vena cava right there in red. So we have these 2 openings, 2 veins. This is the, let me back it up a little bit. This is the superior vena cava here and the inferior vena cava here. That's how we get the bulk of the blood back into the right atria. Now this little red dot on the inside here, this is the orifice, the opening of the coronary sinus. The blood that's coming back in from this large area here, this large blue area, this is the coronary sinus back here, and all that blood is being dumped into this little opening, this little red spot right there. That's the 3rd opening into the right atria. So we have the openings for the superior and inferior vena cava, and we have the opening for the coronary sinus. Okay, now let's move on. So the atria are the receiving chambers. They're under low pressure. Blood just flows right into the atria. The blood is constantly flowing into the atria under very low pressure. We don't have to pump blood into the atria because the blood's coming back to the atria from the veins. The pressure in the veins is somewhere between 0 and 10 millimeters of mercury. The atria, the right atria receives, we're going to call it deoxygenated blood, even though it's less awkward to say deoxygenated as opposed to blood that's lower in oxygen from the body. Comes into the right atria. The walls are very thin in the atria. The walls are on the back wall. We have what are known as the pectinate muscles, and the outer covering of the atria are called auricles, and the auricles let you enlarge the atria. Because if we have to increase the blood flow coming back to the heart, we use these auricles to do that. but blood is under very low pressure and it's constantly coming in. So as I said, the superior vena cava, the inferior vena cava, and the coronary sinus bring blood back in to the right atria. The coronary sinus is returning blood through the coronary veins that are running parallel to the coronary arteries. Now, the left atrium receives oxygenated blood on its 4 pulmonary veins. We have pectinate muscles in the auricles of the left side to expand its size if necessary. And this is what, again, what we see with the atria, the 2 atria, right and left. We see the pulmonary veins. There are the opening for 2 of them, and the other 2 openings are hidden back in here. Over here, we see the fossa. We see the fossa ovalis as a landmark. There's the opening to the superior vena cava here and the inferior vena cava here, and we don't see the opening for the return flow from the veins. Okay. Now in the ventricles do most of the work. The ventricles are actually the true pumps, because remember, the atria are going to be receiving blood. The atria are receiving blood passively. It's coming in under very low pressure, and the atria are wide open. There's nothing to impede the flow of blood into the atria. The ventricles are controlled by a series of valves. The right ventricle takes up the anterior surface of the heart. If you look at the heart model, you can see that the right ventricle is more or less tilted so that it's slightly in front, and the left ventricle is slightly in the back, so it has more of a posterior approach. The right ventricle pumps only to the lungs, and it has to stay at low pressure because the lungs are so sensitive that we can't deal with high pressure going to the lungs. The left ventricle has to pump to the whole body, so it deals with high pressure. Now, if we look inside the chambers of the ventricle, we're going to see structures called the trabeculae carni, or carniae. These increase the surface area of the muscles on the walls of the ventricle. So they're ridges, so we have more and more contractile tissue. We also have what are called papillary muscles in both ventricles. Papillary muscles are the anchors for what we call the chordae tendineae, the strings that hold on to the heart valves. So we have 2 structures, the trabeculae carniae. These are the ridges of muscles inside the ventricles, and the chordae tendineae are the papillary muscles which hold on to the chordae tendineae. Now, what does all that look like? Well, first of all, let's take a look at the size of the ventricle. Look how large the left ventricle is compared to the right ventricle. Now, they're both going to send the same amount of blood out each time. If we're sending out 75 mils of blood to the left to the systemic circulation, we need to send 75 mils to the lungs. But the left ventricle is much larger. The walls of the left ventricle are much larger because it has to generate much higher pressure to pump that blood to the whole body under pressure. The blood pressure in the aorta, the aorta is that large vessel coming out the middle of here. This is the aorta between the superior vena cava on the left-hand side and the pulmonary trunk on the right side. And in the middle, we have the aorta. The pressure in the aorta is probably 120 or 100 to 140 millimeters of mercury, because that's the pressure of the blood that is needed to get blood to all parts of the body. The pressure in the pulmonary trunk, the vessel on the far right-hand side, is only between 10 and 20. because the pressure to get to the lungs, first of all, the lungs are very close. And second of all, you don't want to have a lot of pressure in the lungs, but you need a lot of pressure in the aorta to get to everywhere. Okay. So now if we were to make a transverse cut in the heart, you would see again, the size of the right ventricle compared to the left ventricle and the thickness of the wall. Myocardium, the muscle area of the left ventricle, is much greater than on the right side. So now the valves in the heart, there are 4 sets of valves. The valves control the movement of blood through the throughout the heart. Now, the first set of valves are the atrioventricular valves. They are the valves between the atria and the ventricles. What they do is they will close the AV valves. Abbreviation is AV valves for atrioventricular. When they close, they allow the ventricle to become a sealed chamber to raise the pressure. We close those valves and we seal the chamber. Now, the semilunar valves are the valves that lead to the pulmonary trunk at the very top of the picture there, the one that keeps popping open and shut and open and shut. That's going into the pulmonary trunk. That is the pulmonary semilunar valve. You can't see the aortic semilunar, but the aortic semilunar is on the left-hand side. That's what you're looking at as the right-hand side. It's on the left-hand side of the heart, tucked up just about the same location as the pulmonary semilunar, but underneath it. So, because the aorta is, as we'll see when we actually start cutting up hearts next week, the aorta and the pulmonary trunk look like they're in the wrong place, but they aren't. The aorta is that middle artery. You see the 3 arteries lined up here across the top. That's on an artery on the right-hand side. But the middle artery, you see the middle vessel, is the aorta. Okay, now, so these are the heart valves, and we look straight down into them. We have what's known as the tricuspid valve. That's the atrioventricular valve between the right atria and the right ventricle. Notice that it has 3 flaps to it. On the left-hand side, we have the bicuspid or mitral valve between the left atria and the left ventricle. It only has 2 flaps. The semilunar valves, the aortic semilunar and the pulmonary semilunar, both have 3 flaps. And they're called semilunar because each portion of the flap looks like a moon. At least that's what early anatomists thought it did. So we name stuck. So, and again, here is our mitral valve on the left-hand side. Here is our tricuspid valve on the right-hand side. Here's the aortic semilunar, and here is the pulmonary semilunar. Looking at the heart proper for real, we can see that the semilunar valves have a cup-shaped structure when they come together. So, okay. The purpose of the atrioventricular valves is to seal off the ventricles. It's to prevent backflow into the atria when the ventricles contract. That's what they do. The tricuspid valve has three cusps, 3 flaps. It's between the atria and ventricle. When that valve contracts and shuts, then you don't get blood flowing back into the right atria. See, blood doesn't get pumped from the atria into the ventricles. Blood flows passively into the heart, into the right and left ventricles through those valves. It's only top. The only reason that we contract the atria is to top off the ventricles. Now the mitral valve is on the left-hand side. It has two flaps. It's between the left atria and the left ventricle, and it does the same thing. It closes off the left ventricle so we can raise pressure in the left ventricle and send blood out to the body. And so we don't get blood going back into the atria. Now these things called the chordae tendineae, these are strings. They look like the shroud lines on parachutes. The little strings attached to the flaps of the valves. And those strings attach to the papillary muscles. When the valves close, excuse me, when the valves close, it is those strings, the chordae tendineae, pulling on the valve flaps to pull them shut. So in the papillary muscles, which are attached to the chordae tendineae, when the papillary muscles contract, the strings, the chordae tendineae contract, the valve flaps go shut. And so we now have a sealed ventricle on each side. With a sealed ventricle, we can now start contracting. And we start contracting, we start raising the pressure because we're squeezing the blood inside the left ventricle, squeezing the blood inside the right ventricle. Fluid doesn't compress. If you take a water balloon and you squeeze a water balloon, the pressure inside the water balloon is going to start rising. If you squeeze the water balloon hard enough, you're going to get wet because the pressure would exceed the strength of the balloon. But in the heart, if you raise the pressure high enough, you'll force open those semilunar valves. So what do these things look like? Well, they're the chordae tendineae. They're the strings that are attached to the tricuspid valve. They're pulling that valve shut. They're holding it in place. The papillary muscles are pulling on those strings, holding the valve shut so the right ventricle can compress, can contract, and raise the pressure inside the right ventricle. At the same time, the same thing's happening in the left ventricle. If you look over here at the mitral valve, you can see the chordae tendineae there attached to the mitral valve, and the papillary muscles are below it. Papillary muscles on both sides, on the left and right side, pull on the strings, hold those flaps shut. With the valves closed, the right ventricle and the left ventricle become sealed chambers that we can now start compressing the blood inside and raise its pressure. Now, the only way out of those ventricles is to cause the semilunar valves to flip open, because the semilunar valves are being pushed on by blood that's already in the pulmonary trunk. They're being pushed on by blood that's already in the aorta. To get those valves open, you got to raise the pressure of the blood in the right ventricle high enough to force open the pulmonary semilunar, and high enough to force open the aortic semilunar. So here we see, when our valves, when we are at rest, when our heart is at rest, and the rest phase for the heart takes up most of the time of the cardiac cycle. Cardiac cycle lasts 7/10 of a second. Most of that time, a heart's at rest. And while the heart's at rest, blood is passively flowing through the tricuspid valve and the mitral valve into the ventricle, into the ventricles. When we get ready to contract the ventricles, the atria will contract rapidly and top off the last 20% of blood that's available in the ventricles. Then the valves will go shut. And now we have to start squeezing the ventricle to raise the pressure high enough to force blood out through the two semilunar valves. This is what the mitral valve looks like when it's open and shut, open and shut. Every 7/10 of a second, this thing is opening and shutting and opening and shutting. That's what gives us a heart rate of about 70 beats a minute. We can see the flaps opening and shutting here. We can also see the fact that they're not closing properly because there's something wrong here with this mitral valve. But what's happening is when the valve shuts properly, the animation is working fine. When the valve shuts properly, when the papillary muscles contract, they pull the chordae tendineae and they pull the flaps shut to seal the ventricle. Most of the time, those valves, yes,
So my sister has a heart murmur.
yes.
So what exactly does that mean? Like, I'm asking because like I don't know exactly like which part of the heart.
Okay.
Is that?
The most common heart murmur occurs at the mitral valve.
Okay.
See, and
Or I guess actually it's not a heart murmur. She's a hole in her heart.
she's a hole in her heart. Okay.
Sorry.
Well, that's okay. I'll answer both. Your sister with the pretend murmur. So
Yeah, think about it. Sorry.
don't tell your mother I said that. But the typical heart murmur frequently occurs at the mitral valve because the mitral valve has to put up with very high pressures all the time. A murmur occurs when the valve doesn't close properly and we get some backflow into the atria. That's what's happening on the left-hand side there. You can see that the valve isn't going shut. So when the ventricle contracts, it shoots most of its blood out to the aorta, but some of it goes back into the atria. And that creates a gurgling or gushing sound.
Okay.
And that's the murmur.
Okay, because I actually think, now that I'm thinking about it, I actually think she does have a murmur because she recently went to the doctor. And I remember her talking about it with my mom because they had to do an EKG like over the course of several weeks. So I actually do think she has a murmur, but she also has a hole in her heart. So.
Okay. Well, the murmur is nearly always caused by the mitral valve not closing properly. It gets, it's tired of all the pressure put on it, and it's a very common occurrence. Many people have murmurs that go for years living with it because if it's not causing a lot of trouble, but it's usually because the valve, the flaps get overworked, or maybe they were defective to begin with. So now the hole in the heart, usually in most cases, you can have holes in various locations, but the usual location is between the septum, between the atria, the right and left atrium. The fossa ovalis, the foramen ovale, the fossa ovalis doesn't close completely. That's entirely possible. Less common, but still possible, is an opening in the interventricular septum where you have a connection between the right and left atria, and right and left ventricles. The most common problem with the hole in the heart is simply that the foramen ovale didn't close properly. So.
Well, because I know that like she's always her whole life has been told like she can't go scuba diving, she can't, parachute out of a plane or anything like that because from what I remember her saying, like her doctor basically was like, your heart is going to, if you try to do that, just don't do it.
Okay.
So.
Well, now, it may very well be that the hole is in the ventricular septum, because many people go through many people have a hole in their heart, it didn't close, and they may never know. They might see that their heart has to work a little harder to maintain their blood pressure. They're probably at greater risk for stroke later in life, maybe, but you don't know. Because if it doesn't cause you any trouble, and the only way you'd ever notice it is if you had a echocardiography, ultrasound of the heart, you were complaining about something, or maybe you were just having a routine checkup and just go, oh, look, you still have a hole in your heart. You're 50 years old and you have a hole in your heart. Okay, well, hasn't bothered you yet, but that doesn't mean it won't.
Right.
So.
I actually have a different question, and I should have thought of it during lecture, but I just thought of it. So she and I both work at the Wellkey over on Veterans.
Okay.
But anyway, we had a patient come in, and of course I can't say too much, but we had a patient come in on Saturday, and she said that she had an abortion, but she came in and she started showing like little mini stroke symptoms. So my question is like, how does that go together? Like, you know what I'm saying? Like, I just don't understand how that, unless like the abortion was like, I don't know how to say it, but like, I just don't know how that would go together. the abortion and the stroke symptoms?
Well, it could be that the abortion caused blood clots that would block the vessels in the brain. Maybe her blood pressure went way up and she caused generally strokes are caused by a couple things. Either there's a blood vessel in the brain breaks and you bleed out and compress brain tissue and you damage it because again, fluids don't compress and you're cutting off oxygen supply to a certain part of the brain. That's one way. The other way is to develop a clot and the clot moves to an area in the brain and blocks off blood supply. So either one of those are those are the two most common causes of strokes. Now, I don't know whether, what medications that she used, if she was, where she had the abortion, was it a legitimate procedure, if there is such a thing.
Right.
But, but I would say that it's one of those two conditions there, maybe the stress, maybe I don't know why she would maybe she's throwing clots for some reason or other. It depends a lot on the medication too.
Okay. I was just curious because we don't usually have patients like that come in because we can't do much for them and then things we can send them straight to the ER, which is what we did. So.
Yeah. So I had a student years ago who I forget what surgery she had, and she had a birth control patch on her back that she'd forgotten about. It was just, this is like 20 years ago. It's like the first year I was here, and she'd had this surgical procedure and she'd forgotten about the patch that she had that gradually released the estrogen and progesterone. And so she spent a week in a recliner and she started developing blood clots because of the presence of the estrogen and the fact that she wasn't moving. So yeah, blood clots, I would bet it's probably something to do with the blood clots.
Okay.
But I wasn't there and I'm not a doctor.
I was just curious.
So, okay. So you stole my thunder, but
Yeah.
we call it a prolapsed mitral valve, where the mitral valve fails to close properly and blood literally gushes up from the ventricle, and you get this gurgling sound. So instead of a normal heartbeat, you don't hear the second valve closing. You hear just this, like with a murmur, you would hear a lub sound because the blood's flowing back and forth, and the sound of the semilunar valves are all masked. So, yes.
Can it cause a lot of problems or not really?
For a murmur, it depends. It depends on how much is blowing back into the atria. If it's on the right-hand side, it probably doesn't cause a lot of problems anyway because you're dealing with low pressures. On the left side, it can, because remember, if you're sending blood back into the atria, that's blood that's not going out to the body. So to make sure that you get an adequate perfusion, enough oxygen and everything for all the cells, you got to increase the heart rate. The heart has to work a little bit harder to make up for that blowback that's taking place. And the harder you work, the more blood you're pumping, but the more blood that's coming back. So it's sort of a catch-22 in there. But generally, the heart may raise the blood pressure a little bit. It may increase its heart rate. If it's something small, the problem is that something small tends to get larger over time. So it might be the kind of thing that nothing happens, or maybe you have to just, okay, you've got a murmur and you've got to watch it. So, and watch it every year and see what it does. Or you've got a murmur and we need to fix it right now. Don't move, that kind of thing. So
How do they fix it?
you could replace the valve. You can modify it. You can replace the valve. You can repair the valve. It just depends on what's going on. Both of them are fairly straightforward procedures. You can use a cadaver valve. You can use a synthetic valve. Because the valves, if it's a cadaver valve, it works very well because you just tie the muscles into the chordae tendineae. So the I don't know how they attach like an artificial heart valve. I don't know how they can make it work, you know. I know that you can hear the clicking sound of the valve going shut and opening and going shut, you know, back and forth. So, yes, that's okay.
So, my dad, he had to have an unexpected triple bypass in November. Because he had been having some, I don't remember exactly what it was. He'd had some little procedure done before that, and they had wanted him to come back in for a stress test after that. And when he did the stress test, I think he said like his blood pressure got up to like 180s, 200, something like that. And they're like, "You're not going anywhere," and they admitted him. But my question is like, what exactly does that kind of thing entail? Like what? Because they thought that they actually thought that he should have already had a heart attack and was dropped dead.
That was encouraging.
Yeah, they literally were like, "You should be breathing," which was terrifying. But like, what exactly goes into that kind of procedure?
A stress test?
Or, well, not a stress test, but the triple bypass.
Oh, okay. Triple bypass. Usually what they'll do is if you have a blockage and see the heart has, this is a heart, and you have the coronary circulation across here. Here's the right coronary artery. Here's the left coronary artery. And you have this large one down the middle, the anterior interventricular artery. And if there's a blockage anywhere in here, in any of these, then what the heart does is develop a series of workarounds, angiogenesis. You know, I mentioned that in lecture day. But these are going to be small vessels, and they can't deal with, you know, demand. You know, that's what the stress test probably showed us, that if you're sitting around and you're just walking or doing normal everyday things, this workaround is okay. But if you've got 95% blockage in one of these major arteries, when you go to try and walk up a flight of stairs or do a stress test or put any demand in the heart can't deal with that. And that's where people end up having their heart attack. So what will happen in a bypass procedure is it's exactly what it sounds like. You'll take another artery. The old procedure was to take a large vein out of the leg and put it here and put it here and bypass the blockage.
Okay.
And it's simply you cut into the artery above and below and put the vein in. It's a large vein here called the great saphenous vein. It runs the whole length of your leg. And apparently we don't need it because it can be taken out. Well, it's been found that veins have a greater propensity to develop blockages than arteries do. They you know, so people that have bypass with a vein end up, if they're not careful, end up getting those veins blocked too. So the newer procedures is to take one of the veins, take one of the arteries that go to the mammary glands or to the vertebrae where we have numerous extra arteries, and take one of those and bring it down below the blockage so that you only have to make one cut here to tie it in. And you know, you cut it up here and you cut it here, as opposed to having to take the vein out, cut it, and then tie it in and tie it in. And it's a much simpler procedure. Now, triple bypass means that that's done at 3 different locations, or quadruples 4 different locations. So it's a much more efficient approach to use another artery to come down below the blockage. And then it gives you time to use medication to get that blockage, you know, cleaned out. And so what they do is the blood flow then is now going, you know, they're getting good blood flow in the muscle below where the blockage was. And that's a very straightforward procedure.
Okay, because I'm pretty sure, if I remember correctly, that they had done something to his leg. So they might have done.
They probably took out the great saphenous vein. That's still a good procedure. It still works. It does require a lifestyle change, you know. Of course, some people are, you know, they eat all the right things and they still get heart disease, you know. And then you get the people that have, you know, chicken fried steak every night, and there's nothing wrong with them, you know. So it just, many people usually do have a change of life experience after that happens. Now, another procedure that is also very common is the use of a stent. And a stent is the least invasive procedure in your heart. This is the heart, and you've got a blocked artery right here. The stent is like a little balloon with a little metal frame around it, and you run that in through one of the large veins in your leg, and then up at the blockage, and then you inflate the balloon, and that compresses the plaque that's blocking the artery up against and reopens the artery, and then you drop off the stent, and the metal framework of the stent keeps the artery open. And you do that, and you know, you have an incision in the leg, and it's pretty much, that's, you know, you do it 3 or 4 stents, and that's all you do. Stenting's been around for probably 10 or 20 years. Bypass has been around longer than that. Both of them work very well. It just depends on how much damage the heart, you know, how much damage you're trying to prevent in the heart and how healthy your patient is. Our pastor's wife just had triple bypass 3 months ago, and she's at the point now she can walk around again by herself and drive a car. She can't get into his truck because when you have bypass surgery, they usually have to cut open the ribs and wire them back together again. So she can't get up into his truck because it requires her to step up, and she can't pull herself because of their healing. You know, stenting doesn't do that to you. It's just depends which is the best. So sounds like your dad had the okay, yeah. Yeah, they use bolt cutters to cut the ribs, to break the ribs up.
Well, then they have to use the rib spreader thing.
Yeah, then you have to pull it apart too. So anyway, good questions. Thank you. So I must have gotten really boring because you started taking me down rabbit holes. No, that's good. That's good, because I was like, you know, can I make this any more boring? This is exciting stuff, and I'm making this, well, there's this hole here, you know. So anyway, this is the tricuspid valve. This is the one on the right-hand side. It has 3 flaps. I've often wondered why we have 3 flaps on the right side when we're dealing with low pressure, and only 2 flaps on the left side when we deal with high pressure, but that's just the way we're designed. And we have the flaps, when the valve goes, when the strings pull the valve shut, it's so we can raise the pressure inside the ventricle. That it's designed to create a sealed chamber. Looks like you're going to ask a question.
No.
Okay, I just,
No.
okay. So now here we can see them both side by side. You know, ultrasound is amazing. What you can see this way, you can see the movement of the, you know, this is better than any kind of X-ray or MRI. And particularly when you have echocardiography in color, you can see which way the blood's going, you know, using Doppler radar. But we're seeing that, you'll notice that the valves open and shut together. They have to be synchronized. They have to be sending the same amount of blood to both sides of the body, to the lungs and to the body, have to receive equal amounts of blood. Now, another view here. This one, I really like the one on the right. This is ultrasound, but it's also been processed through probably some sort of MRI. But now you can see how the valves are opening and shutting at the same time. And if you look in the background, you can sort of see the semilunar valve all the way in the background behind the big valves as they open and shut. So and different angles give you different things. So now, okay. So heart murmurs, you asked a question about heart murmurs. It is usually caused by an insufficient or incompetent valve. That's how we describe it. The valve doesn't close completely, usually the mitral valve, and we get a backflow of blood into the atria, and we get a gurgling sound in here. And that tells you that the valve's making a noise, and we can tell it's usually allowing backflow when it gurgles. Now, if a valve has stenosis, meaning it has become brittle and doesn't shut properly, we see this a lot in the aortic semilunar. Then we hear a clicking or squeaking, a high-pitched squeaking sound, because the blood is, we want the valve to open up, the semilunar valve, we want it to open up, but we hear this shrill sound because it doesn't open properly. So, how you're driving down the road and you got the window open just a little bit and you hear the whistling of the wind going by, when you're driving really fast. You nodded your head when I said really fast. That's what you're forcing the blood past these brittle edges here. And atrial stenosis is a common problem too, because the aortic semilunar deals with lots of high pressure, and if it gets brittle, it's going to restrict flow to the aorta. We don't want that. So, and of course, we call it valvular regurgitation, when the blood's going back up into the atria, even though it's supposed to be going into the aorta at the same time. And here we see, this is the color echocardiography of the heart. We can see, if you look, you can see the blood's going one direction. We see all the blues and the browns, but some of it's going the other way. You can see, if you look very carefully, you can see a lot of browns and maybe just a hint of yellow up in here, telling you that part of the blood is going in the wrong direction. So it's amazing and this is old technology. This has been around for years. So again, there's mitral valve prolapse. It's like the same Doppler radar we see in TV telling us, it doesn't tell us it's raining, but it tells us which way the storm, it tells us it's probably raining, but it tells us which way the storm is coming. Well, here we can see the direction of the blood flow through the chambers of the heart. Here we have the mitral valve, which is with its regurgitation. We see the valves are being closed, but we see a color change as some of the blood's going back into the atria. So, and the semilunar valves, and this is, semilunar valves have no strings. They're cordless. There are no chordae tendineae in here. The semilunar valves work strictly by a change in pressure. The semilunar valves have three cup-like structures shaped like this, and they're forced open from underneath. When the pressure inside the ventricles gets high enough, these valves are going to flip open, and they're going to stay open until the pressure in the pulmonary trunk or in the aorta exceed that. When the ventricle pushes the blood out, the ventricle had to raise the pressure in the ventricle higher than what was in the pulmonary trunk. But once the pulmonary trunk pressure ends up greater than the ventricle, then the blood drops back down and shuts the valve. Same with the aorta. Every time the heart contracts, we force some blood out through those semilunar valves, but we can't sustain that pressure. And so when the pressure in the ventricles drops, the blood in the aorta and the pulmonary trunk shut that valve. And this is what the semilunars look like, looking straight down onto them. You can see that they're just three cups coming together. And when they're open, they open towards us on this image. And we're looking at it from the position of the blood that's in the aorta, blood that's in the pulmonary trunk is going to push those valves shut again. Just the pressure inside the ventricle forces those valves open just like this. And when the pressure drops in the ventricle, then the blood that's already there is going to force those valves shut. Just like that. And this is the aortic semilunar valve opening and shutting. Every time it shuts, it's because the blood is, if we're looking at it from the perspective of inside the aorta, we're looking down on the valve from inside the aorta, and what we're seeing is the valve going shut as the blood rushes up against it. The valve flips open, blood comes towards us, and then the blood that's already out in the aorta pushes it shut again. Opens up, shuts, opens up, shuts. So, of course, this is a pretty high heart rate too that we're seeing there. Now, okay, already said that already. Now, this is that example of stenosis. The flaps become calcified and brittle. Notice how the flow is significantly reduced. On the image on the left, we're seeing a healthy aortic semilunar valve. On the image on the right, we're seeing the valve when it's restricted through stenosis. It becomes very brittle. It won't move. It won't respond. Okay, last thing we'll talk about today, because it's already we're actually pretty done pretty well. Heart sounds. The heartbeat. The typical heartbeat is a lub-dup sound. Lub, low pitch, dup, higher. So we go lub-dup, lub-dup. That's how the heart sounds occur. The first sound that you hear are the AV valves going shut. The atrioventricular valves, the mitral and the tricuspid and the mitral give us that low-pitched lub sound. They close first. The second thing that we hear are the semilunars. They give us the higher-pitched dup sound. So, because they can close rapidly, because they don't have any strings on them either. So we get a lub for the AV valves and a dup for the semilunars. Now, if you know what to listen for, you can hear that the mitral valve will close before the tricuspid. So even though most of us will hear just a lub sound, if you listen carefully and know what to listen for, you'll hear the mitral valves close just before the tricuspid. So the left side closes before the right side. Same holds true on the aortic semilunar. It closes slightly before the pulmonary semilunar. So you can listen for differences with these valves closing if you know what to listen for. So, okay. So let's stop here. We'll continue with this next week. Now, next week, I plan on having the hearts here so that we can dissect them. They will be messy. They'll be very messy. We've had, I've done this a couple times in this classroom, and I'm just glad we don't have carpet on the floor. So old clothes, yes. I will not be wearing a white shirt next Monday. Oh, I'd probably forget, and come in. No, I have a nice red shirt that I like to wear on a heart day. So, my wife, however, would look at the bloodstains in this shirt and say, it's a challenge, and she'll get them out. I don't know how she does it. So, okay, let's call it a day. We actually got 43 slides done, so that wasn't bad. So.